job today is just to give you a case study on the European Atlas of Access to myeloma treatment. So these are my declarations, both from Myeloma Patients Europe and my other role at Myeloma UK. So these are the things I'm going to cover very briefly. I'll talk a little bit about who MPE are, focus a little bit on the European Atlas of Access and what the timeline is going to be for the conclusion of the project. So Myeloma Patients Europe was launched in October 2011, and it's a registered not-for-profit in Belgium. We've got 36 members, patient organisations from 27 European countries, so it's fairly representative of Europe. We have an elected board of directors, elected from the membership, and the vast majority of people on the board have a connection to myeloma one way or other. We have, thank you. We've got two very, very competent staff members, a project manager and an operations manager. And like most organisations of our type, we're funded by pharma, but also luckily unfortunately, we have some other support from other organisations and institutions too. So these are our strategic objectives. I always talk about strategy because without strategy you don't achieve much. So we worked very hard at MPE to make sure that we had a strategy. And I think the ones in red are the ones that are most relevant for this discussion. So one is around strategic capability and strategic capacity. Because without the capability and capacity and advocacy, you're not going to be successful. And I think the temptation is always to try and boil the ocean and do too much. And I think we need to boil a few pots and achieve success through doing less but doing it better. And the other thing we're passionate about is minimum standards of care and timely access to new treatments. And that's really what the Access of Atlas was about, was trying to understand more clearly in a more evidence-based way what the problems of access were. On the hypothesis is that if you don't know a problem, if you can't characterize a problem, you can't get solutions. And on reflection, when we look back at the 10 years of advocacy in myeloma, we hadn't achieved as much as we would have hoped. And it's because we didn't really understand what the issues were, and therefore some of the solutions we came up with didn't work. And this slide just, I think, focuses in on this need for a bit of a evolution stroke revolution in cancer patient advocacy from, certainly in my experience, one of emotion and anger, and one in which is focused on just the end of the spectrum when drugs come to market, to actually being involved as co-pilots rather than passengers in the whole clinical discovery and development program. So that when we actually get to market, it doesn't look like Beecher's Brook on the Grand National. It just looks like a small stream that we have to jump over in order to get access. So we've worked very hard at MP to try and think differently about how we want to advocate for the next decade to make it more strategic, more business-like, and ultimately more successful for the patients that we represent. And as I've alluded to, what we've lacked is evidence. And that's why we've not come up with the right solutions. So we haven't really fully understood the problems. And as all of you will know in the audience, Europe is not the same. It's very heterogeneous. Things can be different within hospitals, between hospitals, even in the same country and between countries. So without really understanding what the factors are locally, nationally, and at a European level, that are impacting on access issues, we have no hope of finding the proper solutions. And keeping in mind that most of our members are short on resources, they're short on staff, but yet they have a huge burden and responsibility on their shoulders to try and ensure access to the people that they represent within their countries. So having evidence is really, really important. We then need to know what to do with that evidence, so we need to be very strategic. We can't be ad hoc, we can't be reactive. We need to be proactive, business-like in terms of what we do to ensure that we'll have some successes. So our strategy was to be very clear about what our goals were going to be. And again, we didn't want to boil the ocean. We wanted to focus on the things that really, really mattered and could make a huge difference within a country. We wanted to develop a roadmap, so hold the hand of our members through that journey locally in terms of improving access and dealing with the issues and barriers within their country. And most importantly, learn from and not repeat mistakes that were made in the past, but also to repeat the things that worked in the past. And then we invest a lot in skills. So for us, it's not about just producing a document and having it sitting on the shelf and collect dust. It's about what is the adoption and diffusion and implementation platform to turn the evidence and strategy into real action that can make a difference for patients. So we work very closely with all of our members, and we train them, work with them, mentor them, and create capacity within their organizations locally. This was our methodology. Getting evidence, as most of you will know much better than me, involves a whole lot of desk research. So we had a comprehensive approach to desk research, both at a European and local level, that included looking at clinical guidelines, health system information, health technology appraisal information, things about pricing, reference pricing, a whole range of parameters to really try and drill down as to what the problems were responsible for the lack of access in different European countries. We also conducted a survey amongst our members and amongst healthcare professionals, and I can share or give some insight into some of that data shortly. These were the outputs. So we've created a report. It will be due for publication very, very soon. We have an interactive map on our website where you can go in and you can search different countries and select different data and different parameters to find out what's happening in terms of access across Europe. And we're already working on our implementation plan to try and translate all of this into local and European-wide advocacy plans in conjunction with our members. So this is quite hard to read, but it gets easier in a couple of clicks, I promise you. So these were along the top were the parameters of the survey, and on your left is the responses from clinicians and patients. And what we wanted to do was to be absolutely sure that we understood local issues and to see if there was any discrepancies in the perceptions of what patients thought the barriers were versus clinicians. And as you can see here, there were some discrepancies that were statistically significant. So these are the things we need to focus on locally to truly understand what is going on. So is it a perception of patients that there's an access issue and what the reason for that was versus the kind of doctor? And even where the perception's similar, it still needs interrogation, either because we may have missed something, or this could be an example of good practice that can be translated into areas where there is a discrepancy. Sorry, you can see that easier. And this is a different tool that we use to try and analyze the data and to try and highlight the differences on these parameters between different countries. So whereas the previous slide was differences in perceptions between clinicians and patients in terms of barriers to access, this is geographic differences. So you can see a sort of split in the top between Western European countries and Eastern European countries. So at the top, you see more green than you do red, which means there are less perceived access issues compared to those below. But careful interrogation and analysis of these things has shown up some really incredible data that relate to the previous slide, particularly in relation to clinical trials, where clinicians feel there's often clinical trials available that can increase access, whereas patients don't. There's a big discrepancy. So in terms of our timeline, I think it's fair to say it's taken slightly longer than we'd hoped, but it was important to get this right and to get the analysis right, because it matters to our patients that we get it right, because we're going to invest resources in this project. Our goal is to launch very early in 2016. We'll communicate and disseminate to our members in the first 6 months of next year. We'll do all our implementation, and we'll select a couple of our members of the 26 or 27 to do proof of principle in terms of implementation so that we know our strategy is working. And we'll do an impact assessment in late 2016, early 2017, hopefully to demonstrate success. I think things take time to be successful, so I'm not expecting a huge success rate in the first 12 months, but I think it will gather momentum thereafter. And we don't want it to collect dust on the shelf, so it's a dynamic atlas and it will change over time. So in conclusion, our hypothesis is that unless you really understand a problem and the factors that are impacting on access locally, we have no hope of finding solutions and using very scarce resources well enough to benefit patients. We know that access issues are heterogeneous and complex. Our view is that while the myeloma community deserves huge credit for what it's done in the last 10 years or so, we recognize more needs to be done, and we need to change the way that we advocate. And in the next decade, advocacy will only be effective if we work together, if we have a thorough understanding of the barriers and issues and logjams, have proper empirical evidence in which to base our action, have a clear strategy, targeted solutions, and a skillful community to ensure success, and to really support our members at a local level. So thank you very much for your time, and I hope that was interesting.